welcome. I'm just going to give a very brief introduction. We changed the schedule a little bit. So Dr. Burks is going to start off because he's got to drive all the way to West Palm Beach and get a good head start before traffic. So I wanted to welcome everybody to the 5th annual Jackson Technological Symposium on spine. I wanted to thank our sponsors, but most importantly, make the statement, and especially after looking at everything that's out there, that nothing moves in this field very quickly without the support of our spine exhibitors and manufacturers. And there's several people in this room, who've had long-standing collaborations with different companies, and you can just see how quickly an idea can be transformed into a product. Unfortunately, much quicker than we can at a university-based system. But there's quite a few examples of that, and we deeply appreciate the sponsorship here today, but just the ongoing collaborations that we have every day in the OR to support patient care. And we're happy that some of our staff came out to watch, who help us get the surgeries through the system. So I want to thank all of our exhibitors in general, but specifically for Web Medical, DePuy Synthes, Medtronic, Globus, Invasive, Pantheon Surgical, Providence Medical Technology, Silene, Stryker, and that's it. Why don't we have Dr. Burke's slides?
Good morning. So most of the focus today is on spine, but before we get into that, I'm going to go and discuss peripheral nerve repair. And there's a couple ways that technology does come into this, and especially in the coming years, hopefully we'll be able to incorporate some new tech. Here's some grant funding, and we do have some research support from Integra. So that's important in this conversation. So just the structure of nerves, we have 3 layers: epineurium, perineurium, endoneurium. Here's the more interesting slide here, because sort of these cylindrical tubes are going to be what the axons grow into after repair. So you really have to have something present for the axons to grow into, and we'll talk about how conduits may offer some support there. The repair in nerve is complicated because there's this complex vesicular anatomy. This is a retrograde labeling of a monkey median nerve. They injected dye in the hand, and you can see how the fascicles basically are totally interwoven and move as you go more proximal on the nerve. So even if you knew exactly how you wanted to stitch it, the vesicular anatomy can never be reestablished exactly. So these are just some challenges that we face. How does it happen? Once the nerve's cut, what exactly happens and how does it regrow? Well, firstly, you have this neuronal reaction and changes in the cell body, and that's mediated by 3 major factors, including electrical activity, deprivation of signaling molecules, and retrograde transport of new signaling molecules. And then at the tip, once it starts growing again, you have this growth cone that responds to cues in its microenvironment, and then it also travels down a particular structure, like we talked about, those hollow chambers that it would traverse down, and it looks something like this. In a nerve crush injury, you still have intact those hollow conduits. You have not disrupted the connection at all. So in a crush injury, the axons grow back exactly to where they were previously. And you can see that here on this image between these 2 slides. Whereas if you have a transection injury, you have some disorganization at the suture site, no matter how well it's brought together. So this is another challenge in nerve repair and severe injury. You can see how that kind of looks. You have some axons, literally going 180 degrees, coming back to where they started. What happens distal to the injury? Schwann cells re-enter the cell cycle. They participate in clearing of myelin debris. They proliferate. And then there's association with growth factor signaling. You have Wallerian degeneration that occurs. Basically, you have a latent period after nerve injury where the distal nerve for about 2 days has the same ultrastructure, and it can still conduct electricity for up to 48 hours. And how fast do axons grow when the nerve is cut? We like to say 1 millimeter a day, 1 inch per month. And there's some pretty good data on that. The problem is if you have multiple suture sites, there is delay in crossing the suture site. So you have to incorporate that into your estimation of how long it's going to take. Crossing the suture line, as I mentioned. So let's talk about clinical factors, and then let's get into some of the new technology here. These are all major factors in determining, particularly patient age, in determining how someone does after a nerve repair. The nerve complexity, like the accessory versus the facial nerve, repairing the facial nerve, even under the best circumstances, you still have synkinesis of the facial muscles versus repairing an accessory nerve. It's strict motor nerve and it's only innervating 1 or 2 muscles. So those results are much better. The proximal steal phenomenon, distance to the injury site, you can have degeneration of the motor end plates. So all this plays a role. Here are the different injury types. This is the sort of most complicated one, neurotomesis, where you have this very severe injury to the nerve, and then we have an even more detailed grading system. These are the Seddon and Sunderland classifications. And then this is just, I always like to throw this in there, the rule of 3s, I think is reasonable, or the rule of 2s you could call it, but let's say 3s just for the sake of memory. So clean transection of the nerve should be repaired within 2 to 3 days. Blunt laceration, 2 to 3 weeks. And then a severe injury in continuity, 2 to 3 months. This is what we can talk about that offline. So let's talk about some of the techniques in nerve repair. Basically, everyone does this where they suture the 2 ends of the nerve together using 8-0, 9-0, or 10-0 sutures. And that's done under the microscope. Repairing the nerve with gap. This is where everyone's sort of putting a lot of stock in research involving conduits, and that's what I'm going to go into now. But what can you do to fill this gap besides harvesting nerve from the leg? And this kind of the fancy name is axon guidance channel. These were introduced a long time ago. Originally as just hollow tubes. Basically, the nerve ends won't reach each other unless there's tension. So instead of having the 2 nerve ends touch with tension, you just have a hollow conduit filling the gap. But axons don't grow well through a long hollow space, so we need to fill it with something. And authors, have sort of said that if it's a large diameter nerve or if it's a long gap, then the axons are not going to go through a hollow tube. So then that brings us to this 2nd generation conduit, which we've been looking into in the lab. This is something made by Integra, and they have these longitudinally oriented structures, basically hollow cylinders within the tube that axons can grow into. And so that represents a major advance in this space. So this have been tested in the lab. We have looked into it, but it still lacks cells essentially. It doesn't have any growth factors, doesn't have any cells. So when you harvest sural nerve from the leg, it's packed with Schwann cells. So we thought, how can you enhance these 2nd generation conduits? We can add Schwann cells to them. And so we did that experiment. We showed that adding Schwann cells to the conduits does enhance peripheral nerve recovery, similar to autograft, basically just taking this is in an animal sciatic nerve rat model. You cut the sciatic nerve out, flip it around. That's like the artificial gold standard. And then we compare that to the conduit with and without cells. And the conduit with cells perform similarly to autograft. So that was nice. And this is just how we loaded them. But, in trying to translate this to humans, we have to factor in that we can't use in this rat model. The rats are so genetically similar, we can just have a stock of cells and we can put them in at the time of surgery. And obviously that's not the case with humans. We have to harvest these cells 2 to 3 weeks beforehand through a small sural nerve biopsy. So we have to spin some of the sural nerve through a separate procedure to generate all these cells. So that obviously is a bit prohibitive. It's certainly a disadvantage, but we know how powerful the cells are, so we have been doing it. But what if there was another option? And so that brings us to this idea of exosomes, extracellular vesicles. They have a particular size, and it's basically generated from a fusion of the multivesicular body with the plasma membrane, and that causes them to release. They're filled with genetic material and proteins, and it's actually a cell signaling, basically cell signaling vehicle. And they have certain CD markers, CD63, 61, and CD9 to identify them. And they're essentially generated by just taking Schwann cell culture, spinning down the Schwann cells, but not like just a one-time spin. It's all this differential centrifugation and then ultra centrifugation down to a very concentrated solution or pellet. And then you get this basically exosome solution. And if we could, basically our idea is to take that exosome solution and put it into the conduit in place of the cells, compare it to the cells, compare it to the acellular conduit. And if we can show that possibly the exosomes have the same sort of benefit that the cells do, then we can quickly, more easily move into human experiments. So that's what we're going to be working on here in the lab with those Integra conduits that I showed you, with the longitudinally oriented hollow tubes, and we'll be filling them with exosome, which is sort of this ultrafiltrate of a cell solution. And hopefully this doesn't have the downside of immunoreactivity and the difficulties with harvesting cells. So that's the game plan, and that's what I wanted to talk to you about today regarding exosomes. But just before I finish, I'll quickly mention the human clinical trial that we have ongoing. And we recently received support from the DoD as of this month, actually, for a 4-year study looking into this. Basically, just what I was explaining to you, harvesting autologous Schwann cells from patients, basically 2 to 3 weeks prior to definitive repair. And then at the time of definitive repair of their severe nerve injury, we would essentially implant it into the repair site. And it would look something like right there, look something like this. So we have, we've requested 12 patients from the DoD. We'll be studying them longitudinally for at least 5 years. And that study is funded as of this month. So any kind of severe nerve injury, we kept it, relatively open-ended, sciatic, brachial plexus, and or major injury at the upper or lower extremity. So anything where we feel like with the typical repair, we're not going to have the tools we want, and we don't think the patient's going to have a great outcome, they would be a candidate for this trial. So that's everything. Thank you.
No, I just wanted to reiterate that, Shelby is just in his first year and has gotten a DoD grant for this work. He has another DoD co-investigator grant with WashU in St. Louis. He didn't talk about that, looking at nerve transfers for spinal cord injury, and a recent Glaser grant, which is kind of unofficial, but I mean, that's an incredible amount of stuff in a very short time. So congratulations. I'm going to talk about rheumatoid arthritis surgery, and it's sort of innovation, maybe in like a not instrumented way, but it actually has to do with innovation in medications, and that will be really part of the talk. But innovations in medications in these patient population has actually kind of reduced the surgery that we do in these patients. I've always been fascinated with rheumatoid arthritis patients because of how debilitating it is, but how incredible like patients they are. Like they have all of this disability, horrific pain, and for the most part, they never complain. And I've never kind of understood how strong most of these patients are. It's incredibly debilitating. This is, you know, the typical rheumatoid hand that you'll see with ulnar deviation because the joints are essentially being eaten up by the disease. And it's rheumatoid arthritis is pretty uncommon. Osteoarthritis is incredibly common. Everybody in this room has osteoarthritis, which is, except Dr. Green. Everybody in this room has osteoarthritis. It's just basically as you get beyond the age of 18, you know, you start develop arthritis in your joints to a faster or slower extent. And it can happen in your hips and knees and back. So in rheumatoid arthritis, totally different. Rheumatoid arthritis is an inflammatory arthritis, and it's basically inflammation of the lining of the joints. And essentially through mediators, and this is going to be important in a second, like TNF alpha and cytokines, there's inflammatory cells that leave the blood system and then head into the joints and just start eating up the synovial lining, and they get horrible arthropathies from that, joint swelling, stiffness. And it can also affect the skin, the eyes, the cardiovascular system. So you can see the incidence is 2.1 million people in the US. So that basically means 1 in 300. So 1 in 300 people have rheumatoid arthritis. 100% of people get osteoarthritis. But again, very difficult, very different. It can start in the 20s, but most of the patients that we see, and this is a real challenge, are in their 70s, 80s, and 90s when they need surgery. And that presents its own challenges of how to do surgery in that age group. You know, the way we treat it for the most part is like NSAIDs and corticosteroids, and they're very effective. But the problem is that it gives relief of pain, but it doesn't negate the destructive effects of the rheumatoid arthritis. So and they often have side effects from it. Their skin is incredibly fragile. So this is kind of the important part of the talk, is that we've always had disease modifying drugs in rheumatoid arthritis, and some of the common ones are methotrexate, and that's also used in cancer. It inhibits cell division. So if you inhibit cell division, you can inhibit inflammation, but obviously it has a lot of negative effects. And then hydroxychloroquine, not only good for COVID, but can also be used in rheumatoid arthritis. But what's really very cool is these biological DMARDs, and they've been around since the early 90s. When they came out, they were like horribly expensive. It would be like $1,000 a dose, per month for these patients. But now it's much less expensive because the patent has worn off on them, and they are incredibly powerful against rheumatoid arthritis. They do have some side effects. You know, there are rare cancers and infections and things that can happen, but super powerful drugs. And so that's really helped the rheumatoid population for sure. And I'm going to show you what we think has been the effect on surgery. One of the challenges in these patients, but also in any of our patients that we operate on, and we're trying to get a fusion, is how to handle the perioperative medications like steroids and anti-inflammatories and stuff. And these are some studies that have been done showing that in general, as the nurses here know, we try not to give them anti-inflammatories perioperatively in the first 12 weeks in general, because that inhibits fusion. But there is evidence that like the COX-2 inhibitors like Celebrex and Vioxx, which is no longer in the market, are much less detrimental to fusion. And these are some studies in rabbits showing that when you compare like indomethacin, which we definitely try to avoid, and ketorolac, which we avoid, that celecoxib is not that bad on fusion, especially when you look at radiographic fusion. So if in the rheumatoids, you cannot take away all their anti-inflammatories because they're gonna freeze like the Tin Man on the Wizard of Oz. You have to give them something. So we often do give them a little steroids and anti-inflammatories, even if they're post-op fusion. There's evidence not only in animals, but in patients that you can do this and not have horrible results. So again, the message is, and particularly for the nurses that I see in the back there, that it's, at least in my patients, I'm okay with a little bit of that, in the perioperative period. So why do we do surgery on these patients? It's either for pain, deformity, or myelopathy. And, it's really hard to tell if a patient with rheumatoid arthritis has myelopathy because their limbs are so deformed that, the traditional tests of like hyperreflexia and things just don't work because their joints are so affected. So there are some simpler scales that we use and it's pretty gross, but that's often the way we can tell if patients are getting into problems, is simply like they used to be able to walk with a walker and now they can't anymore, or they have some symptoms of numbness that they didn't use. So that's called the Ranawat scale. And something that I've noted, and I had mentioned to the residents, is that I certainly early on in my career, I was treating a lot of patients with rheumatoid arthritis. And then as I got older, I found that I didn't see as many patients with rheumatoid arthritis that needed surgery. And so we'll get into why that might be, but these are the reasons why you would operate on the cervical spine in rheumatoid arthritis: either basilar impression, which basically means the head is settling on the spine; C1c2 instability; or subaxial disease. This is a pretty common question on the oral boards in terms of how to manage these problems. And again, something that, looking at the database is that while non-rheumatoid patient surgery numbers would go up every year, the rheumatoid patients would go down. And we'll talk a little bit about why that might be. But before we do that, and we have 5 minutes left in the talk, is basically looking at some of the common problems and solutions. So like I said, C1c2 instability is pretty common. This is an example of a patient with rheumatoid arthritis. And you can see when they flex and extend their neck, their C1-2 joint is highly mobile. That ADI is about 10 millimeters. It shouldn't be any more than 3. So that's definitely abnormal. And you can see that while there's a lot of room in the spinal canal, the cord is very atrophic. And that's essentially because the dens is hitting the spinal cord every time they move their neck back and forth. So that's just a case for C1c2 fusion. And again, through technological advances of using screws as opposed to cables, the fusion rates in these patients have increased significantly. This is an example of a transarticular screw with cables supplemented by iliac crest bone graft. This is one of the few cases where I actually use iliac crest bone graft because their bone quality is so horrible that if you put a hard allograft in there, it just doesn't settle as well as using their own bone. So, we take iliac crest grafts so rarely these days. It's almost like, novel when we do it in the OR. And just some of the important landmarks is the superior cluneal nerves, so that when you make your incision, you want to make it parallel to these nerves, not perpendicular, because if you do, then you'll cut them. And then you're harvesting crest, and you don't want to go too deep. If you do, you can hit the superior gluteal artery and have problems. And then we cabling this bone graft in between C1 and C2. Another common problem we see is basilar impression. And that's basically when the skull settles onto the spine. There's a bunch of lines that people have described to talk about how to diagnose cranial settling. I certainly cannot remember all of them, but these are the ones that are being described. I tend to use the simplest thing, which is the Wackenheim-Clival canal line, and that's basically drawing a line along the clivus. And if the dens sits on top of that line, you know that they have basilar impression. And you can see if you do have that, then you can start pinching off the cervical medullary junction. When I was training, we used to do a lot of transorals for rheumatoid arthritis. Now it's known that if you just do a reduction and fusion, you can get rid of this pannus without having to go through the front. This is an example of an occipital-cervical fusion and showing the screws, subaxial and fixation to the skull. And then the last thing that we can see is subaxial disease, which is, shown here with someone with kyphosis and instability and a stair-step deformity and cord compression and signal change. And so that person ended up with an anterior posterior decompression and fusion. And then sometimes you'll see patients either who need revision surgery or have all of these problems. So this is an example of a lady who has had C1c2 instability. They tried to do wires. She never fused. She has kyphosis in the mid-cervical spine, and she has basilar impression. And you can see how these wires are bowing into the canal, causing cord compression and myelopathy. And then she has subaxial disease with stenosis down here. And so she ended up with a occiput to sort of T1 fusion to try to treat all of these things, including iliac crest bone graft. So just to get back to the beginning, talking about like the declining incidence, we looked, and led by Roberto Perez Roman, at the incidence in my series, but also in the literature and using Medicare databases, that in fact the incidence has gone down over time, and most likely it has to do with the use of DMARDs. And even though it was instituted in the 90s, it obviously takes time to have the biological effect in reducing the joint involvement. And so in my personal series and what was seen in the Medicare databases, that it seemed that while cervical spine surgery is going up, rheumatoid arthritis surgery in the cervical spine is staying flat, and it's probably due to the DMARDs, and it affects the subaxial and OC1. It affects C1c2 and OC1 surgery more than subaxial surgery. So that's all I have on rheumatoid arthritis. Happy to answer any questions. If none, I'm going to introduce Dr. Wang, talk about minimally invasive surgery.
Yeah, Alan, I found that, it's sad because those are like the best patients. Those rheumatoid patients they're so grateful. They're not like your typical spine patient. It's kind of sad to see them go. I hate to say it like that, right? The nurses know that. So we're here back for our annual technology summit, and this is really wonderful. I'm really happy to have the honor to speak to you guys today, and really want to thank the companies. I'm going to change gears a little bit. My talk's going to be a little different in flavor than the others today. I think I don't want to bore you to tears with what you guys already know about what I do. So I like to show this slide because when I was a medical student, this is what I thought I'd be doing, all these cool brain surgeries, and we will have a similar brain summit coming up later. But I don't do any of this stuff anymore. Okay, so for the last 20 plus years since I finished my fellowship here with Barth and Alan, I've only done spine, and we actually consider ourselves almost like orthopedic hybrids. So we call ourselves neuropods, because if you're going to learn how to do spine, you got to learn all the family of knowledge and skill sets that orthopedic surgeons have and combine them with your skill sets as a neurosurgeon. So I'm going to make this statement partly because the industry folks may not have heard me talk about this, because everybody talks about how great they are, right? Everybody goes and mouths off about how, if you come to this residency, you're independent as a chief, or we do so many cases. But let me show you some real data. So you're in one of the largest spine centers in the world. So this is our faculty, our esteemed faculty in Neurosurgery Spine. And if you look at what's actually happened here, the 6 proximate chairs of orthopedics and neurosurgery are all spine surgeons. Hugh Rosemoff, who founded this department, Barth Green, who built this building and this department, followed by Alan, who leads this department now. In orthopedics, Mark Brown, Frank Eismont, now Fran Hornacek, the new chair of orthopedic surgery. Now, that may sound like, yeah, whatever, right? But let's look at what that really means. So if you were to say that Miami was a place and it were to occur in 2022, it'd be like the Garden of Eden for spine, okay? Because the probability of a chair being a spine surgeon in neurosurgery is 4%. And the probability of an orthopedic chair being a spine surgeon is 15%. If these were unassociated variables, and I know they're not, the probability of that is 0.00000022, which means 1 in 4.5 million chance of Miami occurring. There's about 100 programs in the country, right? So the probability there will ever be another University of Miami for spine is literally, it won't happen. It definitely won't happen in your lifetime. So this is a very special place. And we're talking about spine today. Is it better if I use something? There we go. Because spine is really diverse. Some people think, oh, it's just bread and butter. It's how we pay the bills. It's not. Spine pathology is diverse. Whether you talk about degenerative disease, whether you talk about what Dr. Levy just talked about, you could build a whole career talking about rheumatoid arthritis, infection, trauma, neoplasia, deformity, all this stuff. And if you look at our service line, just take a look at these numbers. Because again, everybody say, well, Baptist is big, or FAU is big now. It's nothing like here. Look at the size of this operations, this number of outpatient visits, this number of operative spine procedures, this number of residents, this number of publications, truly unparalleled in any true academic neurosurgery department. So I'm going to spare you what you can read on PubMed, all the papers that we publish, not important. You guys would be bored to tears at 7:30 in the morning. And it's only possible because we have this tremendous support system, whether it be our physician extenders, APPs, nurse practitioners, nurses, and PAs, or the surgeons and the surgeon trainees that make all of this happen. And it's like a family. It's a very, very special place because it's collegial. And this just shows you the numbers. This is mostly for the industry because they're going to go to another hospital next and they're going to tell them how great they are. But this is the real data. If you look at what's going on, we have the largest spine fellowship in the world, 8 spine fellows, 4 external, 4 internal. We had 9 last year. It's really just a tremendous operations. That's just in the neurosurgery side, right? Now, why does this matter? Because the change is happening every day, okay? So this is what was going on when I started out, right? These were the new cool toys that we had at our disposal. You guys are gonna laugh at this because you look at like ACDF plating. You kidding? Lateral mass screws, right? First lateral mass screw case I ever did was in 1997. It took 8 hours to put in 8 screws, okay? Transpedicular screws, right? That was new. People are like, well, how do I go learn how to put in pedicle screws? Transarticular screws. I came here to learn that from Alan because he came from the BNI. The lateral extracavitary approach, which you guys have never even seen before. This was the new shit. This was the stuff that like, I'm going to go learn this stuff in fellowship, right? And now if you think about what has happened in the 20 years since I finished training, these are the arenas, if you will. I just put a couple of them down where you could actually build a career. If you just took one of these and you said, I'm going to go get that, you would build an entire career as a spinal surgeon. You would be able to be world famous because you would be the world's expert in that. So this is my favorite quote. This is from Charles Darwin. It's not that the strongest survive. It's the ones that are the most responsive to change, because change is inevitable, that survive for the future and build the future for the rest of us. And so there's lots of hot areas to watch, right? And we're going to talk very briefly about that. I'm going to try to spread it around to be even because obviously I favor MIS surgery and robotics, but Jason's going to give a great talk about robotics later. So people always bring this up. They're like, well, listen, if you're going to do this stuff, it's expensive. Some of you guys are going off to your first jobs. You're asking for stuff and the hospital administrator is saying, well, that's going to cost a lot of money. We're not going to get that for you. Well, that's true. So if you were to look at this, I'm kind of a geeky guy, right? So I had early version computers way before you guys were probably even like born, I think, some of you guys. And so we were working with like very, very early generation Commodore products and Apple products and IBM products. If you look at the device on the left and the device on the right, which most of you guys have in your bags right now and Kat's using right now, which one's more expensive? Well, the one on the left. The one on the left, dollar for dollar, inflation adjusted, was more expensive, just like all new technologies are more expensive. But we have an interesting problem here, right? Which is that as you see what happens in America, why America is so amazing and the greatest country in the world, is because we move things forward. We get more productive. We do more with less. year in, year out, right? Whether it's in science, engineering, economics, the growth and productivity per person is greater and greater and greater. The residents today do more than I ever could have done as residents, even though I worked more hours and slept less. They can do more because they're more efficient, right? So what does that really mean? So if you look at the rest of the world, this is the cost of computing power on an iPad 2. So if you go to Target now and buy an iPad 2, it's going to cost about $190, okay? If you trace that back on this graph to that computing power, this is really Moore's law, right? This is Moore's law about information. You go back to the 1950s, that's in the trillions of dollars. Think about what that means for advancement, what that means for us as surgeons. So if you're going to tell me that spine surgery is not going to change and you're just going to take your skill sets that you have today, I would be trying to teach you guys how to put an ACDF plate on. Be like, look, you guys need to train with me in fellowship because I'm going to show you how to put on an ACDF plate, right? That would be what would happen. And you see that. We see that around the country, that people are like, they're frozen in position and where they are. So now why am I saying all this? I'm saying this because we're at a tech exhibit, right? We're here to celebrate our industry partners. And I apologize if I don't get to everybody because of the time. So these are some of our industry partners. Here's the key: innovation, change, exploration, improvement, genius of creativity. This is the key. This is what we're all after as neurosurgeons, right? So I'll show you just a sort of insight into my mind. When I was a second-year resident, I got involved in a project. Michael Levy, who Dr. Joel Martin knows very well. Mike Levy was a young attending at Children's Hospital of Los Angeles, and he said, let's make a new kind of bone wax that's not going to inhibit fusion. I talked to Volker Sontag. Volker was a young man that I'm working with Puronic surfactants for rheology, for vasospasm. Why don't we make a wax? So we made a wax and we patented it. And it was patented during my residency and paid royalties for the next 17 years. It finally expired this year, actually. So a lot of that money's gone to pay for travel and books and loops and various things in this department. And that's a product that's on the shelf right now used by cardiac surgeons. I never talk about it because I have a conflict up until now that I made a good amount of money by doing this. So I encourage the young people today to think outside the box. Don't just go learn so you can innovate, learn so you can do the next thing better. And the benefits are immense, right? I mean, we've seen Dr. Peterson do this recently. There are, of course, financial rewards. There's passive income, but more importantly, there's relevance, connection with peers. You get to intersect with engineers and people who stimulate you intellectually, okay? So if you think about what that means, right? The idea is that you have a concept, a problem needs to be solved. You're going to find a solution for it, and you're going to take that into a marketable, hopefully profitable type of an endeavor. And I think James Badou is trying to do this. That is going to make and change lives for the better, right? So why am I saying this? I'm saying this because I'm going to take you through the different companies and my view of what they do, right? And again, I apologize that time limits us. So these are all fairly large corporations. They have a whole plethora of things they do. I'm going to focus on just one selectively. So Medtronic. Okay, so Medtronic's supporting us today. So Medtronic's probably their biggest product is BMP. This is probably their biggest money maker. Makes about $1 billion a year. We use a lot of BMP here, but the history of BMP is complicated. Most of you guys just think it's a sponge, mix it on the back table, costs $5,000, and you stick it in the body and it fuses it, right? But it actually goes back way back to Marshall Urist back at UCLA when he was processing cow bone. He was processing tons and tons and tons of bone and boiling it down, trying to use protein. It wasn't electrochirography, but it was a way of trying to separate the component proteins of bone and then figuring out what was going to be the key issue here. And of course, nowadays, BMP is genetically engineered, right? So there are, I think, at least 53 BMPs out there. So we use recombinant BMP2, which is a Medtronic product called Infuse, right? We often use it off label. But the idea is this is incredibly powerful. People go, well, BMP's got issues. And when I was a fellow, Alan and I started using it. And I went back to USC and we published, well, we didn't publish, we showed the first cases of neck swelling from BMP. We were probably one of the first 2 groups in the country to do that. So it has issues, but it's incredibly powerful. And you guys know I use it every day because this is something important in terms of getting a bony fusion and maybe disc regeneration, right? So BMP7 was used by Stryker and it never came to market, but there's over 52 BMPs out there, all for regeneration of various components of the body. So if you think about the advance, I think about it this way. This is the beginning of the truly molecular era of spine surgery. Right? This was the birth of it in 2002, that we could use genetically engineered components to reconstruct a human spine, right? And again, lots of issues. The Yoda study, I think Dr. Levy reviewed this a couple years ago, and the Yoda study showed a lot of things. You know, maybe there's some issues here and here and here, but the bottom line is nobody disputes that BMP works. I've never met a single human being that says stuff doesn't work, right? So it works great. And I have nothing to do with BMP, so it's not like a commercial for BMP, right? So if you look at that, there's a lot of opportunity here. If you had just spent your career, one of our former fellows, Kevin Cahill, had a JAMA article when he was a resident researching BMP. One little area, you follow it down into a thread, and you can build an entire career. 4Web. I love 4Web. 4Web is a company that I think was highly innovative in their thinking. 4Web was way ahead in the game. 4Web was interested in this truss technology. So what they did was they took the concept of civil engineering, architectural engineering, and they took it to the spine. And then they involved 3D printing. They were one of the first companies, everybody does it now, to do 3D printed titanium alloy cages, right? So they built an entire family of devices that is centered around this, they call it truss technology. The idea that you don't have to have a solid block of whatever material it is, PEEK, titanium, carbon fiber, bone. You can build a lighter, more elegant way of doing this. And this actually allows better bone ingrowth. So 4Web is a company that I think has a great future and a lot of promise in terms of what it's going to offer. Stryker. Stryker is another great company, one of the top 3 or top 2 medical device companies in the world. Stryker is one of those companies like Johnson & Johnson that spans the entire spectrum. The beds in the hospital, they're made by Stryker, right? So it's not just medical device, right? So if you think about it, Stryker has the entire family of power instruments. That's where they've gone with a lot of this stuff, right? So one of the things I harp on you guys about in the OR is, for the residents and fellows, is you guys are young now. Okay, I remember being young like you guys. I remember being able to go through a 16-hour case without having to go to the bathroom or eat anything. I'm old now. I can't do that stuff anymore. Barth's stronger than me. Barth can stay up later and do more surgery than I can, right? But it has a cost. All of this surgery we do, I've done about 7,000 surgeries. All of this has a cost. And orthopedic and other injuries, psychological injuries, divorce, all these things happen to us because we invest so much in the operating room, right? Just like a professional athlete. So think about the incidence or prevalence of these types of diseases. This is in surgeons, right? Truly phenomenal. We've seen that actually happen on our own faculty here and there, right? So the idea is leveraging power devices to allow you to, say, put in pedicle screws. That repetitive motion of putting a screw in. Right now, you guys are like, yeah, I put a screw in, look perfect, right? Do that 20,000 times, and then see what that does to your shoulder and your wrist, and your carpal tunnel, and your brain, and your eyes, and all the radiation, all that. That has a cost. You don't see it now, but you will see it later. And think ahead to how you can use power devices, right? Like I was trying to change my tire, teach my kids how to change a tire in a car. I'm like, oh my God, this is impossible, right? And then I took it to the shop and they put that little air gun on, and it was off in like 2 seconds, right? So think about working smart, not hard. You should work hard, but you should work hard and smart, right? And power tools will allow you to get there. Stryker Power lets you adapt onto all these various iterations to put in screws, to do various things. And this really comes from the orthopedic world. The orthopedists are good at this, right? Putting in screws in a more ergonomic fashion, not having your arms up here, but down here. This is very important. DePuy Synthes, one of my favorite companies. I love DePuy. Rob and Renee are here. DePuy Synthes, to me, really made their mark when we were doing our first-in-man MIS deformity projects here. We did all these amazing things, multi-level MIS TLIF, mini open PSO, first-in-man, all published, of course. And that was only possible because of the Viper technology. So the Viper technology is the world's leading pedicle screw percutaneous system because it was the first to get small. Everybody copied Viper, right? All the copies are out there now. And this shows what we can do with that type of technology. First-in-man iliac screw in OR27, right? First-in-man lateral mass screws MIS with Alan Levy when I was a fellow. We did a lot of stuff here that's really, really cool. Now it's easy. People just say you do the obturator outlet view or the teardrop view is what they call it. So this is the case that really mattered. This is the case that changed me. This is a gentleman that was at Jackson Memorial Hospital for 6 months. He was on the plastic surgery service. He had a decubitus ulcer, 3-time flap. The plastic surgeons called us and said, we're not going to do any more for this guy. And I had a conversation with his mother. And those of you who've been to clinic with me know that when I have a conversation, it's a conversation. And I said, I don't know if your son will survive. And she goes, how could he die here? I'm like, infection used to be the #1 killer of humans up until about 80 years ago. And now with COVID, we see it coming back again, right? Humans have been reawakened to the idea that nature is powerful. So this guy, what are you going to do with this, right? He's got osteomyelitis. Okay. What are you going to do with a human like this whose wound has essentially been open for the better part of 6 months? In Jackson, right? So, well, we thought about it and we're like, well, we had done that first in man case with burst fracture. And here's what we're going to do. We're going to go in and we're going to try to get in the front, but we're going to use this operator outlet view. This is the first case we ever did, OR27. And the second case was an OR26. And we're going to do percutaneous iliac fixation along with percutaneous pedicle screws. And what that does is, first of all, it allowed us to invent a whole new system. And this is the ORM images showing the proper screw placement. Basic principles, debridement, fixation, antibiotics, nutritional support. And this shows you how it looks. So for the people who are surgeons in the room, you can see all the incisions are remote from the cubitus ulcer, all the devitalization, the sacrum and all that. And you can't do that with an open surgery. Now, maybe you could get away with it, maybe call plastics again, do antibiotic beads, keep them in hyperbaric oxygen. You could do a lot of hat tricks, right? But they tried a lot of this stuff, right? What we did is we perked him and guess what happened? He healed himself. Right? So this is the kind of case that you look at and you're like, wow, maybe there's something to this other than just people wanting to do perk screws. And if you look at the work that Barth brought me to Haiti, that we did, dozens of people who had burst fractures and fracture dislocations after the earthquake in 2010, putting in Viper screws in environments where there are flies all around us and having extremely low infection rates for Haiti, eventually led to the Johnson Medal, which is Johnson & Johnson's award for their greatest product for the year for the Viper 3 system. So really exciting stuff if you look at it, right? It allowed us to do the ERAS surgeries, the awake surgeries, all these elements that are super, super cool by getting really, really, really small. Okay, Nuvasive. Nuvasive is a company I've had a long history with. Very, very complicated history. Ellen knows this, but a very, very creative and dynamic and out-of-the-box type company. Luis Pimenta is a good friend of mine. He's a Brazilian that came to America and helped found this company, which really brought back the anterior approach to the spine. And they did it with three things. One was they came to Miami, actually, and they learned from Blair Calancy about EMG. Right? They learned about this and they used some of that technology. There is a source of a little bit of bitterness, but the point is that they took that and took tubular technology and then they said, we're going to go anterior with this. Now it's all history for you guys now, but it's a history you should know because at the beginning it wasn't so easy. It wasn't like, oh yeah, you just do lateral, right? Everybody's like, wow, this is craziness. They brought thousands of surgeons to San Diego to learn how to do this with these three pieces of technology, and then they owned that space. And if you look at the growth of lateral surgery, and you're going to hear Dr. Yurikov talk about the latest iteration of that, it's really, truly tremendous. And to watch that journey happen and see what's happened with it and the utility and how we have so many more options for treating people, it's really great. It's really led to the revitalization in literature and the awakening of MIS deformity surgery, right? But here's a cautionary tale. This is from a book I wrote on lateral surgery, or I edited, I should say, and this is from the introduction history component by Luis Pimenta. So Luis Pimenta knows more about lateral than anybody on this planet, right? Because he lived through it in Brazil, and he was good enough to put this picture into the book. And if you guys want a copy of the book, I have it in my office. This shows the original approach that he took in Brazil. Now, if you guys ever are lucky enough to get on a design team for a company, some dumbass is going to say, let's do this approach, right? We're going to do this approach. This is the only corridor you can't go down, right? Because this is the area where you go through all the nerves. And Luis tried that in Brazil and it didn't work. So then he came through the true lateral approach. So this is a very important slide. If you want to remember one thing from my talk, remember this slide, that just because you thought of something new doesn't mean someone else didn't think about it first. And that's why you got to talk to people. That's why you got to go to meetings and meet people other than Miami people. You got to go out and meet people who are well-known, established, and have the ability to tell you the truth and be honest with you. So, anterior column release procedures, right? I'm not going to go into this. Timmers knows a lot more about this than me, so he's going to talk about all kinds of stuff like this. This is that book I told you about. So Globus, another one of my favorite companies. I first got to know Globus when I was in LA. So basic principles of MIS, right? So MIS principles are not all about percutaneous. Sometimes it's about making the footprint that you're going to go into smaller. So here's a case example of an ALIF, one level correction of a severe sagittal imbalance, and someone's entire spine's been fused except for the one remaining level at 5-1. And so that's possible because we can use expandable cages and hyperlordotic cages, right? So Globus really made their mark initially by micro machines. They came out of the Synthes group, and David Paul built a group that was very, very capable at building things faster and more efficiently. And they built the first peak expandables. This is very difficult to make a plastic machine that's going to have enough power to jack up the spine. They are the masters of expandable cage technology. Now they have the Excelsius robot, which we have at Jackson. We're lucky to have it. Timmer's leading that charge. Really, really amazing stuff that's happening with Globus, probably the #4 company in the world. And if you see what they do, all their micro machines that they have, all various kinds of cages that expand in 2 dimensions, in 3 dimensions. So the take home points, it's important to be well-versed, learn all the techniques in spine if you want to be a spine surgeon. Innovation is critical. If you don't innovate or you don't keep up with innovation, you will be left behind because other people will be better at this stuff. And take a proactive role in understanding biology, biomechanics, engineering, material science, regulatory environments, the law, right? These are things that you should learn when you're a resident. Don't wait until you're attending to learn all this. And this is one of my favorite quotes, my second favorite quote, okay? Because this is how my OR goes. Surgeons resist change, but this is from George Bernard Shaw. He says, the reasonable man adapts himself to the world. The unreasonable one persists to adapt the world to himself. Therefore, all progress rests on the unreasonable man. This is a very important point. I make this point to the fellows, that if you want to be reasonable, good, just go follow the pack, man. But you will not be making any changes except at the incremental level. And I think about neurosurgeons and how we are. I think about these folks, Sir Edmund Hillary, Neil Armstrong, Jacques Cousteau, they were explorers, right? Just like Harvey Cushing, just like Lars Lexell, who invented the gamma knife. Think about all the things that neurosurgeons have invented. It's like almost everything. I mean, it's crazy. It's us, because we are not afraid to be the pioneers, right? Just think about how we think differently about the body and the world, right? And here's a disclaimer, new is not always better. Alan was talking about rheumatologic disease. This is a patient that I was taking care of at USC. And this is a funny lady, because I saw her when I was a young attending, and you can see her neck is a veritable museum of spinal implants of different eras, and some metallic and some not, and some 3D fixation and some not. And I saw her, and she had a non-union, and I was going to do what Dr. Levy showed. I taught me how to do an OC fusion with the new systems. And I drew it out on I used to do this. I was different in clinic. I used to draw everything out. I was like, draw it out, show her, like, I'm going to do this OC fusion. We have this new technology and all that. And this lady in a wheelchair looks at me and she goes, Dr. Wang, I've had 9 spine surgeries on my neck. Every spine surgeon did exactly what you're doing now. They said, we have this new thing and I'm going to fix you. And so this is a disclaimer, because it's important to understand that while you see the changes happening, you're not the final product. You're just a person along this journey, right? So I want to thank our team, our APPs, nurse practitioners, nurses, techs, everybody who's out there, our trainees, because we are in a very, very special Garden of Eden of spine. So thank you, Alan, Barth, for building this place, and to the junior faculty for supporting me, and shameless plug for Neurosurgery podcast. So thank you. Have a good day.
Good morning. Great talk as always, Dr. Wang. Thank you for having me here. It is a pleasure. I would like to talk about oblique approach to lumbar spine in a way, kind of unique, I guess, way of thinking about it. And I appreciate our senior faculty and mentors for allowing me to develop within that space. It would be, I can imagine, very easy anywhere else. When I just started, someone come up to me and say, you know what, you can't do that. No one did that to me here, and that's the beauty of Miami. And I think a lot of good things will be coming out. So oblique approach to lumbar spine. Here are the disclosures, slowly growing them, and they're all relevant. I put this slide to remind everyone that in pursuit of minimally invasive spine surgery, we shouldn't just think about the length of the incision we use. I think there's a lot of systems involved, and all of them should be taken into account when you consider any surgical approach. And of course, what constitutes the minimally invasive procedure? It is about how much tissue is being distracted and open and injured in the process of getting to the point of surgery. It is how much you actually perform on the spine here, from the small procedure to multi-level instrumentation. And of course, the time involved. You can't do a microdisc in 6 hours and say that it's a minimally invasive procedure. And to help us with time, there's all kinds of technological advances. And here I just have glasses, robotic systems, fluoroscopy, and different toys and retractors that you'll see later. to create a premise, right, for this talk, let's talk about the definition of what creates a problem. And for the most part, this is degenerative spine. And I believe it all starts in the disc. Degenerative disc disease initiates the chain event of all the problems that people come up to you with. And not going to get into the theory of what happens to the disc, whether it's nutrient supply, dying off the cells, or repetitive trauma. We'll all see this in clinic at different stages. Patients come in and they have different degrees of subsidence, loss of height, loss of lordosis, facet arthropathy, stenosis, and I believe all of that comes from the disc disease. So let's say a patient comes in and you see these bone on bone, long-standing chronic picture with confirmed axial pain, and we have to restore the lordosis, we have to decompress the foramen. There's a lot of crowding around the nerve roots, and patients can't walk, can't stand, can't be upright within a gravitational field. And of course, different ways of doing it. None of them are right or wrong, and there are different approaches. We could do an open surgery, take out the facet joints, decompress the foramen, which would give us the space to crank on the spine and just use the posterior corners of the vertebral bodies as the pivoting point to create that lordosis. And posterior lateral fusion, and if all goes well, in about 1 year, patient's gonna do okay. Same type of correction can be done by restoration of the anterior column. And this is an extreme case. I don't believe anyone should have this much lordosis in their spine. Obviously, someone went crazy here. But this proves the point. By just restoring the anterior column, by restoring the height of intervertebral space, you can correct the lordosis. Multiple papers on indirect decompression, the foramen and lateral recess, and pretty much everything that an open surgery can achieve can be done through now less invasive and more restorative procedure. And if you're convinced by now, in the short introduction, that, okay, let's concentrate on restoring the height of the anterior column, not just taking bones away, let's put the spine in its original position. That would allow for the lordosis correction, all the biomechanical parameters, the balances, and how can we do it in the least invasive fashion? This is an old picture by now, everyone recognizes it. Different approaches to the disc space, from the most anterior to the most posterior, right? And there's no right or wrong way of doing it. You have personal preferences, as long as you achieve the goal of restoring that intervertebral disc height. Starting out, I've started by doing a lot of T-lifts, as we're pretty well trained in here, and they do well. Many patients do well. It's just I was getting these complications of things that I couldn't control. A case of subsidence. You put a cage and you think, okay, it's anterior enough, it should be well held. Did a good job with the initial placement. Was very happy with the outcome, and patients doing well. And then a couple months later, they're like, oh no, something's back to my preoperative symptoms. And then you look at the x-rays and the cage just engulfed. And in that particular case, we replaced that with the lateral. Or it moves, right? If the discectomy is not adequate enough and reaching for that contralateral corner was not done properly, and there's still cartilaginous tissue that pretty much probably pushes the cage back, you get this migration. And other complications involving too, such as during the procedure, you work right next to the nerve root and thecal sac, CSF leak, nerve root injury. We've had a cage that was malleted into the spinal canal rather than in the disc space. And of course, patient wake up with the foot drop that I'm still following. So all these things kind of led me to believe, okay, got to be a better way of doing it. We're comfortable with T-lifts, we know how to get it done, but let's get outside the comfort level. And then you start thinking about the lateral. And by now, lateral is very common. I guess over the last 15 years that it's been growing, people think of lateral, like Dr. Wang said, it's a go-to procedure and easy. And then you start getting into anatomical variations, high crest. Do you just not do the procedure and think, okay, we tried, let's go back to T-lift? Or you come up with ways of going around it. And by now, every company has a system to help you with the high crest situation where you can come obliquely from different angles. And that it's something that takes us out of the comfort zone of being vertical and horizontal, having straight lines, direct access to the disc space. And now we have to think about angled approaches and oblique views, but gets the job done. And then you see these constructs. People get comfortable with lateral. They start putting lateral cages at the easy levels. And at the 5-1, look at this one. You get the small little T-lift, expandable cage. And I don't know how anyone thinks that could be an acceptable way of, or even equivocal way of fusing it. Why go through the trouble of putting a huge case cage into the upper levels. And when the most important level gets this little pea-size vertebral disc space, right, body. And to me, it's like, use whatever analogy you want, but it does not look that good. You know, it's like spine surgery missed a leg day. You know, it just should not be happening. Here's a picture of the differences of that previous cage where I was telling you about the subsidence, where I pulled out the banana articulating cage, which is usually even bigger than the standard T-lift cages. And that's what it was replaced with. So you can argue about the biomechanics of the lateral approach. But why do people still do this, right? Obviously, there's no maybe system in place for 5-1, which is the lowest level, to get access to it. Maybe there's no exposure surgeon, there's no training, or adding a step of keeping an A-lift and then rotating the patient as to the time in the OR, and people believe then, you know, doing it all through the back and putting that little thing helps them. I don't know, but it's got to change. And sometimes you look at something and you just know it's not going to work, right? It's a time bomb. Here's a patient that just came last week, just serendipitously. As I was getting this talk together, he comes in with exactly the same construct, and the T-lift cage got wiggled out and popped out and was creating problems that we have to deal with now. All right, so as I was saying, direct lateral by now, pretty easy. And I always make this comical analogy, but it's like riding a tricycle at this point. Everyone knows how to do it. We're all comfortable getting that retroperitoneal access, putting the sequential dilation and neurostimulation, and for the most part, doing it safely. But that limits us to just that open anatomy, whatever we can get open with the direct access. What about the other levels? Do we revert to doing a less stronger construct, or what, you know, does not feel as well? Or do you adapt to that and explore other ways? So now coming in front of the psoas and oblique approaches allow you to add a couple more levels to that same surgery. And you know, in my analogy, it's like now you have a bike with training wheels on. You're getting better, you're getting more confident. The remaining level is usually the 5-1. It is, of course, the most complex level. You have to deal with the vessels and complex anatomy and the very variable anatomy. Once you acquire that, that's when you're really ready to take on the high-end trails and do the whole spine surgery now in a single stage, 1-to-1, really have no limitations. Unrestricted access to anterior column now becomes not easy, but doable, right? One of the cases here, 68-year-old gentleman at posterior instrumentation with posterior lateral fusion that just did not take. All of his disc spaces continued to deteriorate, vacuum effect, symptomatic, developed adjacent levels above and below the construct. And we did this case at the VA. As you can see, this is, I think, a DePuy anterior A-lift cage that we placed through the oblique. And that cage is pretty good. And I know Roberto Vivas single-handedly is working on making it adaptable to an oblique approach. And it's an interesting process. He's doing a good job with that. But you can see 3 incisions here, direct lateral at the upper segment, then oblique approach at 3-4-4-5, and of course, anterior oblique approach to 5-1. I put in here, even though the surgery went well, there are still many things that need to be considered. That particular gentleman woke up with the right quad weakness, which is the floor level, not directly in the axis, and most likely because of my oblique approaches at the time, and I did injure him. Incisional planning, as you can see, I used to do a lot of multi-incision approaches because not a single muscle gets cut, and with the woven structure of the abdominal wall, you can't really have one long incision and have a big opening. You have to cut something, so that's why I have multiple incisions. Dr. Scott Spann, who's been doing approaches to 5-1 and lateral since early 2000s, had visited me in the OR, and he saw that and he said, why don't you go through the aponeurosis? And I like that idea. We're exploring that, making a cut along this connective tissue here that gives you an expanded access to retroperitoneal space and really can access many disc spaces in the oblique fashion. Has its own learning curve too. If you make the cut into the muscle, then putting it back together completely difficult, and the muscle just breaks apart. So finding that aponeurosis is my current challenge of making it consistent and reliable, and in a way that I could teach, and it's reproducible. And of course, advantages by now we know. We can restore the lordosis efficiently, can place the larger implant. Maybe not, of course, it's all subjective interpretation. Graft relates to fusion rates. Approaches themselves do not require as much tissue dissection, so postoperative pain is minimal. Blood loss is minimal. as we know from the open surgeries, patients wake up with a lot of pain with that paraspinal muscle dissection. I think this is alleviated here. The concept of indirect decompression by restoring that anterior column, foramen gets larger, lateral recess gets more open, so the nerves get decompressed. And hopefully all of that leads to better short-term outcomes. I'm sure by 1 year, by 2 years, no matter how you choose to do your fusion surgeries, once patient bypasses the risk of complications, they all do the same. But here in the short perioperative term, this becomes very important. And that's all great, but we have to keep in mind, of course, all the bad things that can happen. The approach takes us outside of our normal confidence level. Instead of just dealing with bone, muscle, and nerves, now we have vessels, we have kidneys, we have peritoneum, we have all the other structures that we have to be aware of. And then here's a picture of Dr. Levis and Dr. Benglis's research on where the femoral nerve was. And we know with direct lateral staying more on the anterior side, preserves that function. With oblique approaches, you almost bypass it altogether. By coming down the anterior border of the psoas muscle, you never have to worry about the lumbar plexus. Here's my personal list of things that can go wrong, and I'm sure it'll be growing, and it's still a lot of things in development. But now that we're dealing with this retroperitoneal approach, not direct access, things are angled and very easy to get off track. Keeping the peritoneal membrane intact is important. Because of the angled approach, it's very easy to go along the flank and end up on the posterior border of the psoas, and then you start pushing and pulling on it, and of course you get into the lumbar plexus that way. Sympathetic chain is something that I think became more important now that we are in front of the psoas. And even though personally I could not even confirm that I've seen a sympathetic chain ganglion in my view, I've had patients that come back with unilateral approach site swelling of the lower extremity. It's short term, but still it's noticeable and annoying to the patients. Of course, dealing with the vessels, there's a huge variety of how the vascular structures can go, and we have to be ready. If we're doing that approach, you can't just say, it'll never happen to me. Every case I start, I think, is today the day that the vena cava is going to blow out, or we're going to do something major, and how do we prevent that? And of course, the little peculiarities of anatomy, such as the middle sacral vein, iliolumbar veins, where they are, how do you account for them? All of that becomes important. Segmentals, less so in the lower lumbar area, but more in the thoracolumbar junctions, in the mid-thoracic areas. Of course, again, being at an angle and pushing instruments through a narrow corridor and an angle where the spinal canal is pretty much in line with your approach, you have to be careful. And getting that canal protected is important as well. And like I mentioned with the previous case, contralateral nerve injury. Direct lateral, we know we can always go straight in, and we see that instrument past the annulus on the other side on the x-ray. Sometimes with the oblique approaches, this point of exit can be very close to the foramen, and that's where the DRG is. As we grow our experience, we also see the variety of different complexities. For instance, this gentleman right here, 6'4", skinny, had this 2-level disc disease. It was very symptomatic, could not be upright, has to be bent forward whenever he needs to move somewhere. And I thought he'd be a straight shot. Skinny, I could feel his spine with my finger through the groin, so not a problem. And the first level went okay, the 3-4. But when I got to 5'1", because of how skinny he was, the overall girth of the abdomen is very narrow, and so the movements were restricted. Also, his tissues were very fibrous, and the vessels were interesting in a way where they were large caliber, and as you can see here on this picture, traversing the disc space almost parallel to it. And I couldn't, for some reason, mobilize the whole bundle, either medial or lateral, to gain access to the disc. And so I just ended up needing to split the vessels and go in between to place the cage. And surgery went well, thank God. Only on the way out, I nicked the femoral vein, which is right there at the inguinal opening. And that was fixed easily. But I'm like, oh, wow, after thinking I did everything well, and now we're just getting out, boom, that happens. So can never lose that alertness. I put a 5-0 Prolin stitch on it. It was part of the connective tissue structure, so it wasn't kind of an exposed vein. Sutured it, no problems. No, it was already close to the surface. It was not deep down. Yeah. No, we can talk about complications, how to deal with them. You have to be ready for complication, right? Doing the surgery, having a small approach to 5-1, I don't assume that nothing will ever happen. No, I assume, okay, what will I do if all of a sudden this big vein right here bleeds, right? And there's a whole protocol in my mind that I have how I'm going to deal with this.
It's amazing. I was just gonna say it's amazing. It's the things, it's the all of that. And I'm always amazed when I walk into the room and take care of this.
Thank you. I used to do it with Dr. Abdullah, but then I realized in the oblique approach, he was going through a learning curve. I figured I might as well go through my own learning curve then, and that's how I ended up doing it without him later. Another complexity that being added, a high sacral slope, and you can see on this picture right here where the 5-1 disc space comes very close to the pubic bone. So doing an A-lift would be pretty much you would have to go through the bladder. Here an oblique approach allows you to gain access to that space. And that's where the versatility of retractors come in with every complexity, because the anatomy is so variable and so unpredictable in many ways. You want to have a system that allows you to be flexible, not just, you know, kind of stiff and stuck to the same place. And you can see I've worked with every single retractor that's out there, different systems from the bulk Walter type of circular retractors to an X-lift type retractor that Invasive and Depew and Stryker and Globus have. Medtronic's octopus arm that allows you many degrees of freedom and bulk, you know, and then when you do navigated cases may get in the way. You see different variabilities. The latest retractor that I'm kind of stuck with the Pantheon Spinal allows for that different degrees of freedoms, and really I found it very flexible, and it's very easy to work with the company too. Here's a real picture story. After one of the navigated cases, I call up Sean, the lead engineer in the company, and say, you know what, the retractor handle is in the way of my navigation array. And I just sent him this picture. I'm like, can you take this, cut it like this and connect it like that? He's like, no problem. Next case, I had the retractor ready. The handle is away. I can put the navigation array here, and it went much smoother. So it's nice to have that flexibility. 5-1 space, like I said, is very variable. Probably why many people don't do it. It adds complexity, but at the same time, we have to know how to do it. It's not the first time a spine surgeon will be taking over the area in the body or someone else's surgeon's kind of a niche. And I don't think it's unreasonable to acquire that skill. It also sets us up for the next kind of improvement on the procedure, allowing us to, instead of doing the steps in stages, putting them all together. You know, how we used to do with Dr. Vanny, L2 to S1, L1 to S1 lateral with screws over 2 days. He'd do A-lift and flip, do laterals, and then bring the patient back to do the screws. And that takes a long time. By keeping the patient in lateral, doing all the steps at the same time allows us to save it. Here you have pictures of Kat Berry and I doing the approach. Kat's putting the screws and I'm doing the exposure and the oblique. Here's a picture of all three of us. James Badu doing direct lateral exposure, Mike Yang coming in obliquely through a separate incision. I'm putting the screws in. So all those things are being done at the same time, and now efficiency is growing. Of course, you can say in the smaller places may not be possible, but even then there's a lot of time saved there. And let me take you through the evolution of the single stage approach I kind of been working on, and it hasn't been easy. We started out with just using floor. Here's a case of a 58-year-old gentleman, standard dynamic listhesia that's symptomatic, not really with conservative measures. No fractures, but laxity within the joint. And this is Arya and I doing the single stage lateral position with fluoroscopy assistance. You know, we did it, all went well, but of course, working with the x-ray, we can only be on one side, doing one person at a time, you know, finding the instruments on the x-ray machine. We got it done. It was done, no problem. And post-op outcomes were great, but that procedure itself was not that very pleasant. So for the next case, 64-year-old gentleman with back pain, thigh pain, 2-level disc disease that was very correlating to his clinical presentation. Now we use navigation system. We see Steve Zima with Medtronic manning the stealth machine. And now we can work on either side. There's no machines in the space. That fluoroscopy is gone. Michael is putting the screws, I'm doing the exposure. Now it's getting easier. We're using navigation that makes it much easier to put those screws in. And then again, favorable outcomes, no problems, everyone's happy. Next case, getting higher in complexity. Deformity case on the lady that's been destabilizing in her curve. And here we're using diffuse system with the Viper Prime that's navigated, and I've added a heads-up display with kind of augmented reality field that allows me to just keep in line with what I'm doing, not looking at the screen, exploring that option and making that to see if that's any better. And it did add to how much, not that much, but easier way of putting the screw in. It makes it a little more comfortable, a little more straightforward. This case was on my oral boards, and as you know, I didn't fail, so I guess something, at least it wasn't that bad, right? But also notice how the 5-1, this was from 2019, the 5-1 space was not addressed. And at the time, of course, the underlying reason is I wasn't comfortable with doing 5-1 in lateral yet. She was in single stage lateral. I did not want to spend more time doing prone or A-lift. And clinically, in my mind, I've made an excuse that clinically the 5-1 was not symptomatic for her at the time, so I did not address it. Now, 3 years later, she's coming back and it's starting to bother her, that level and the SI joint. And of course, the latest, the addition of the robotic systems, you can see here on the video. With the robot coming to Jackson, we already had the whole system in place where I think it fit very well without altering our workflow that much, and if anything, helping. Usually, if you think of a robotic system and adding it to a case that's already been established, like you're looking for any other surgery that we do a lot, you would think of a time waste of setting it up and getting it going, and that it's going to be an extra burden and longer procedure. With the single stage lateral, it plugged in smoothly, and it allowed us to really just continue doing our work and even doing it at a much more efficient rate. These are just videos demonstrating that, how the setup, and we have Cadbury on one side putting the screws in, and the robot really helps us with that. This was a 4-level case, as you can see, at least radiographically it looks favorable, and clinically as well. These patients, interestingly, do very well. If I don't injure their contralateral nerve, they do very well. They wake up and they're happy to go home almost the next day. So in conclusion, anterior column restoration hopefully kind of gave you guys an insight that that should be the focus, and kind of we should be thinking about it more rather than just cutting the spine up and cranking it and bending it into a shape that we'd like. Restoring the original height of the vertebral segments helps restore the previous anatomy and maybe help the patient. Oblique and lateral approaches are key for that, and having the full skill set of all levels is important. It's nice to have that in your armamentarium, that you can really target the whole spine, the whole lumbosacral spine, and even thoracic. Now the comfort level, I think with me at least, we went up as high as T4-5, which, you know, people would always say it's impossible to go above 6-7 on the thoracic spine due to scapular and the bulk of the lat muscles and pecs. But now with the modification and positioning and approach, 4-5 felt very comfortable. It wasn't for a fusion, it was for something else, but seeing that level that high in the lateral approach was very exciting. And of course, having the oblique skill set allows you to put the screws in lateral. And also the future of spine surgery, I hope it's not just going to be all fusion. I'm sure there's going to be procedures in place that would allow us to restore the anterior column in some other biologically friendly way, and it will not be a hard cage and fusion material. And having the skill set of being for us to be able to get there by the time that advancement happens will be valuable. Thank you.
I apologize. I think I'm the only one presenting virtually today. I'm actually in New York right now, but I'm glad to have the opportunity to talk to you guys. Today, I'm going to be talking on novel methods for outcomes assessment in spine surgical patients. Here are my disclosures. You know, a year ago, I gave a grand rounds talk when I was very early kind of down this road. And I told you guys that there was a problem with the way we're assessing outcomes. And, you know, I'm not going to go through that whole talk now, but to summarize it, you know, we all know that the current standard for outcomes assessment or patient-reported outcome measures. And what I told you guys is that there's a bunch of problems with those measures. And, you know, one is that they're inherently subjective. You know, it's a survey. Patients are unhappy with their hospital stay, their nursing care. There's a lot of factors that can go into how they fill out that survey that aren't necessarily truly related to their surgical outcome. The other problem is that it's kind of an apples versus oranges thing. You know, there's a lot of different proms out there, and they're non-standardized. So, you know, if one study is using SF36, another is using ODI or EQL5D, you can't necessarily compare the outcomes in those studies. We know there's issues with demographics influencing completion. You know, certain socioeconomic groups are often left out. They're very cumbersome to collect. And I think anybody who's tried to collect these, I'm sure a number of our residents have participated in collecting these surveys. It takes a long time. It's very painful over the phone. And, it has to be done prospectively. In other words, if you don't design a study up front, you can't go back in time and get a 3-month prom, right? If you don't do it, it's not done. And then you have to wait another 3 months for your next patient to come by to go ahead and collect that. And they're non-granular. We pick these arbitrary periods of time, 3, 6, 9, 12 months, and we get the surveys. If we're lucky at those time points, usually we miss 1 or 2 of those. And then we know nothing about the intervening segments of time. And so, after that Grand Rounds presentation, we wrote this article, and I just put it up here. If you guys are interested, I would suggest go read it. We did this in conjunction with Dr. Gogolwal at Leahy Clinic, where we talk about some of the issues with the proms in a lot more detail than I just mentioned. But, kind of that led us down a road of trying to think of a better way of doing things. And ultimately what we arrived at is that activity was a good overall proxy for well-being. And, the reason being, among other things, your overall level of activity encompasses how much pain you're in. Now, certainly there's some patients that will have pain that will push through it and their activity won't be affected, but that would not be the common reaction to pain. It takes into account your general conditioning. It takes into account psychosocial aspects of recovery. In other words, we know that depression is linked to psychomotor retardation. It's objective, especially if it's collected retrospectively. You never knew you were being monitored and that data is being stored. And it's extremely granular. Instead of 3, 6, and 9 months and 12-month data, we have hourly data, right? So we can begin to fill in the gaps of what happens in between those periods of time. But of course, there's also barriers to implementing what we would call an objective activity-based outcomes assessment. Where do you get this data? How do you make sense of it? It's extremely granular, as I mentioned. And how do you correlate that activity to true clinical events? And so when you start to think about this and developing a new novel methodology, in order to be effective, that methodology has to be unintrusive, can't require a lot of work on behalf of the patient. It has to leverage existing and universally held technology. If we have to go and buy something new for every patient to do this, it's not going to work. It has to be relatively inexpensive. It kind of fits with a previous point. It has to be easily interpreted, and it has to be benchmarks to existing methodologies and standards. In other words, what we're proposing essentially is a new language, and we have to provide the ability to translate that language to a language that people understand. So in this case, the language that people speak in right now is patient-reported outcomes, and so it has to be benchmarked to that. And so considering all those facts, we decided to pursue a strategy of smartphone-based data collection. And, smartphone ownership is near universal, and I haven't included it here, but we actually did a study where we looked at it, was there greater participation among younger patients? Did this exclude older patients? And we did not find that. So that's really exciting. The data is constantly and passively collected, right? Many of you don't even know that this data is being stored, but it is outside of your knowledge. The data is very granular, as I mentioned. It can be internally normalized, and we'll talk a little bit about that, but you can be used as your own baseline, which means you don't really have to think about including all this demographic data and trying to equate different patients to each other. There's years and years of data. And I think finally, this point is really important. There's going to be resistance to implementing any new technology, but if people feel that very personal information has to be shared, they're going to be super resistant to it. And so if we were basing, how much activity patients engaged in on GPS data, that would be very problematic, because, we would know what people were doing during their day and where they went. People don't want to share that kind of data. But the data we're talking about has nothing to do with GPS, everything to do with accelerometer. And so the fact that it's based on accelerometer, it's kind of very unintrusive. There's not much you could do if you were to get your hands on a patient's accelerometer data, right? It's not very revealing. And so, I think the talk I gave last year, we left off on this slide. We were in the very beginnings, and we had enrolled our first patient, and we were very, very excited. And the reason we were excited was because even with this very simplistic graph, which basically we took weekly average steps and we plotted it, we saw this beautiful trend, which was that this patient had a low level of activity prior to surgery, and this vertical dash mark is the date of surgery. Then they had surgery, the activity got worse, but then it rapidly kind of improved, exceeded their preoperative level of activity. And then they had the secondary decline. We're like, that's interesting. What is that? We looked in the chart, didn't find anything. And that coincided to the onset of the coronavirus pandemic. So this got us really excited because, we didn't know if we were going to find any signal in the data. And this seemed to show that there was a signal, but of course it was one patient. And in reality, this was the very, very beginning. We were just kind of hitting the tip of the iceberg. And there was a lot of work to be done in terms of making sense of this very granular data. And so this is our first kind of big paper that we published on this in a Red Journal. And we were able to enroll 23 patients in the study. And these were all awake endoscopic fusion patients. And, this is the first graph, which is just like daily average steps taken across all the patients. And you look at this graph and you cannot make any sense of it, right? It's completely useless, raw data, a lot of noise here. But when you start to begin to organize this data in a meaningful way, you start to see like a really, really beautiful and for us exciting trend, which was that you could see here, this bar graph here, and basically we've grouped all these patients together, and we're using a 6-month preoperative period to 2-year post-op period. And you can see this is their preoperative activity. They have a statistically significant decline in activity after surgery, as would be expected. And then they have a rapid recovery. And actually, by 3 to 6 months post-op, they've exceeded their preoperative baseline. Now, they go back down after, but again, all this data was collected during coronavirus pandemic. So the fact that we saw this trend, again, just for us speaks to the fact that there is something meaningful here. And this is exactly the trend you would hope to see for a minimally invasive approach. We also started to put a little bit more work in terms of matching the activity data to the clinical course. And we went in the chart and the patient said, on about 2 weeks ago, I hurt my back lifting something, boom. We put a hash mark there. It corresponded perfectly to the decline in their activity. Then they had surgery. We put another hash mark, again, another decline, as you would expect. At their 2-month follow-up, they said, I'm doing better. And as we saw in the chart, that correlated to them exceeding their preoperative activity level. So, starting to understand that this data does correlate very well with self-reported clinical history. But again, we wanted to keep improving on our understanding of this data. Doing simple graphs, I think, is not enough. Again, this is very complex data. We want to begin to start to model the disease and intervention cycle. And this is one of our more recent papers. Actually, I think we got the cover of the May edition of Red Journal for this particular paper. And this one's a little different. Basically, we took 14 patients who had undergone lumbar decompressive surgery, and it was for both central stenosis and herniated discs. And we downloaded their data, and we began to build what we call epochs, and I'm going to explain that in a minute. But I want to take a quick aside here, because I think a major criticism of this approach early on is going to be that we don't capture a large percentage of patients. And what you see in this particular study is that looks to be true, right? There were 249 patients we identified. We contacted 116 of those. Of those, 82 owned an iPhone, 34 agreed to participate, and only 14 had all the data that we required. And so those numbers don't look great. But I think the reason for that is, one, these were patients who hadn't previously participated in research. So we're essentially getting consented for, getting them consented was difficult and challenging to begin with. Introducing this idea of pulling their data, which is a novel concept outside of the office setting, was also challenging. And at this time we were limited to using iPhone because we only had an app that would do it for an iPhone. I'd say today, we believe that the best way to do this is to consent patients in clinic. I think that'll result in a much higher hit rate. And we now have the ability to do this for iPhone or Android, so that eliminates that particular issue. And so I think you'll see the capture rate of this, and certainly as you reassure patients about the safety of this data, our capture rate is going to go up and up and up. But basically, we were able to define what we call epochs, 5 different epochs, but you could just think of these as periods of time. And what we want to do is, we don't want to have to go to the chart to say, okay, the patient said they got bad, and then we put a hash on our graph and say, okay, this is when the patient got bad, and the patient say they got better, and then we put a hash there, because that doesn't really leverage the technology as much as we could be. What we want to do is try to impute from the data when they declined, if they declined, when they got better, if they got better. And that's what we did with this particular algorithm. And you see these 5 periods. The first is a preoperative baseline, which is their usual state of mobility. Their acute preoperative decline, if they have an acute decline. If they don't have an acute decline, we assume it's chronic. Their immediate postoperative recovery period, and then a full recovery if they achieve it, and a secondary decline. And I've included all the criteria for that here. I'm not going to have you guys read through that. If you're interested, the paper is available to you. But just to give you an idea of what that looks like and how we do that, we start with the raw data here that you see on the graph on the top. Then we start smoothing that data. by doing 7-day moving averages, again, starts to look more coherent now. And then finally, we overlay this algorithm. And you can see this is pretty kind of exciting stuff, where you see this preoperative baseline period as identified by this red area of the graph, this acute decline that the algorithm appropriately identified, this recovery period, which is the light green, and then what we define as a recovery. And then finally, in this particular patient, they had a secondary decline, and that secondary decline again was identified by the algorithm. And in a minute, I'm going to actually talk to you about this particular patient and what happened with them. But what we found in this study was that there were essentially 4 different patterns of recovery in this small patient population. The first was patients who had acute decline, followed by a full recovery. And you can see this patient had this low level of activity followed by an acute decrease. And then finally, this what we call full recovery and maintenance of that recovery. There's another patient who had no acute decline. And actually this patient, when you look at them, they were a central stenosis patient, which makes sense. It wasn't like a disc herniated and they got acutely worse, and a full recovery. This next patient never got better without an acute decline. And then finally, there's this patient who had a secondary decline. And so you can imagine, you know, when you start to identify these trends in patients, what this can be used for and what it will be used for ultimately, and we're working towards, is predictive modeling to understand which patients will recover, which ones won't, how much they'll recover, when they'll recover. You know, a lot of our patients will ask us, you know, after my surgery, when will I get better? When will I get back to my normal, you know, activity? And, you know, we don't really have a good answer for them now. We say, you know, well, you know, you're going to have pain for the first, you know, few weeks are going to be pretty bad. By 8 weeks, pain should be a lot better. You know, 3 to 6 months, you're going to be, you know, feeling pretty much normal. You know, but we're kind of making up those numbers. We're able to actually quantify that now. And I think that's one of the really powerful things of what we're doing here. Obviously, we need to validate this data. You know, does it make sense? And when you look at the patients we identified as having recovery and the ones that we said don't have recovery, and you look at their mean pre and post-operative steps, it makes perfect sense. You know, these patients with recovery had a decline prior to surgery and then recovered and exceeded, this is Z-score normalized steps, exceeded their preoperative activity level. And then the patients without recovery, obviously, these patients actually got worse. And so that obviously falls in line with what we would expect. I want to show you guys a specific patient example to kind of bring this home. This is a patient who presented with a herniated disc, and the point A on the graph represents their acute decline and actually corresponds to when they came to clinic and said, you know, I'm starting to feel like I have some pain. So we see that identified as acute decline by our algorithm. They, you know, in point B, they come to clinic and they said, actually, I'm not doing so great. This was the recovery period. And that correlates to the depressed level of activity after surgery and actually a decrease. And now you can see the difference between the PROM data and our data. The 60 and this 50 represent the EQL5D data. So there's 2 data points here. And it shows you this very narrow window, which is what we're defining as our post-op recovery window. And they said, yeah, you know, I'm getting a little bit worse. And, you know, that bore out in the data that we saw. And then we see us identifying their recovery period. And in C, they come back to clinic. And at that time, they said, yeah, I'm actually feeling a lot better, which again, correlated. And then finally, our data shows that they got worse. Again, it had a secondary decline, and it took them a while to come back in. But when they did come back in, which is point D here, they told us, you know, I'm feeling like I have my pain back. An MRI was done. It shows a reherniation of the disc. And so again, just I think a really beautiful example of how this data correlates pretty much perfectly in this patient to their clinical course. But you know, there's a lot of work to still be done. I think each of these, what we're calling epochs, is an opportunity for further investigation. We have to understand each phase of that. And so one thing we wanted to understand was this concept of the decline, acute versus chronic decline. Is there a difference in the patients and how they look? And so we came up with a definition of what we called acute decline. And we basically said that any, you know, if they had a decline in activity within 5 months before the date of surgery for greater than or equal to 10 days, and that decline was sustained, that counted as an acute decline. Otherwise, we would consider them to be chronic. And we compared fusion patients versus decompression patients. And these were awake endoscopic fusion patients versus simple lumbar decompression patients. And based on this algorithm that we built, you know, we showed that in a vast majority of our fusion patients had chronic decline, which is exactly what you would expect. And a vast majority of our decompression patients, most of whom had herniated discs, had acute declines. And again, that's not surprising data, but I think it's really nice to be able to identify that and understand the difference between acute versus chronic decline and how that may impact recovery. We wanted to validate this against the clinical history. So we went to the chart, and we looked at what the patients told us, and we compared that to what our model showed. And I think our predictive accuracy with a permissive threshold, in other words, if we said any decline below baseline that's sustained counts as an acute decline, we had 100% accuracy for laminectomy with fusion. If we did a strict threshold of 0.2 standard deviations, that accuracy went down to somewhere around 40-something%, I think. And for the fusion patients, it was actually the opposite. If we had a very permissive threshold, our accuracy was less accurate, and actually makes a lot of sense. These are patients who have chronic pain, periods of relapse and remittance of their pain. And so if every time they have like an acute exacerbation of pain, we say, oh, this is an acute decline, that's really not accurate. That's a chronic patient with chronic pain who has an acute exacerbation. And so actually in those patients, using a strict threshold resulted in a higher predictive accuracy of about 67%. So again, kind of what we'd expect to see. So just wrapping up, I think our most recent study, I think is perhaps even more exciting. We all want to prove that our interventions really make a difference for our patient. Tim was just talking about the oblique approach, and how do we show that that this is actually superior to the way the way that we've been doing things. And in this particular study, we're actually comparing the recovery profile of our endoscopic fusion patients to simple decompression patients. And we say that awake endoscopic fusion is better because it's less invasive, it's short surgery, less muscle disruption, patients are up quicker with less pain, used with an ERAS protocol. And what we see here is that the recovery profile of our endoscopic fusion patients is virtually identical to a simple decompression patient. So of course, this is one piece of the puzzle. This doesn't show that fusion is better than decompression, that there's not problems associated with fusion. But the idea that the decompression has the same recovery profile of a fusion, I think is kind of astounding and again, novel. So, what's the future here? I think we need to continue to validate and understand each period of treatment recovery from an objective activity lens. We want to do more large-scale validation of prompts to objective activity metrics. That's that translation, of our new language to the existing language. And I think ultimately, as we gather more data, the plan is to use the data extracted from these analyses to build predictive models, AI, machine-based learning. Thank you.
As Jason gets up, I'm just gonna thank everybody again for coming. And I had a quick question for you, Greg. I don't know if you can hear me.
Yep.
But why did you pick a 6-month pre-op time point in that original neurosurgery paper? I would think that if you picked a shorter time point, you would have seen a more impressive result.
Yeah, that's a great question. So one of the things that we found is defining that preoperative period is super, super important. I think early on, we didn't have a great way to define it. It becomes a little bit arbitrary when you start doing really short windows. You may not be capturing some of the chronic decline in activity. If you pick a window that's too long, obviously you're going to have other problems like other comorbidities creeping in. And so that's why we've moved towards now and kind of an algorithmic definition of a preoperative baseline, as opposed to saying, okay, it's 6 months, 3 months, because that's not necessarily accurate. And I agree with you. I think, in that early paper, that it's somewhat of an arbitrary distinction because we didn't have enough knowledge to understand how to define that. But that is very, very critical.
Okay, so a lot of good talks today. I'm gonna fly through this so we can get to the device display and get everybody to the clinics and the ORs. Let's see what we have. Okay, great. So real quick, we'll talk quickly about the state and current evidence related to robotic-assisted spine surgery. Quick overview, there's a couple different types of robots when we talk about them. There's master-slave systems. These are systems where, the robot's entirely dependent on surgeon activity. That's like the Da Vinci. Active systems like industrial robots that basically do whatever you program them to do. And then semi-active systems, which are what we're dealing with in spine surgery, which are basically guidance systems that require a surgeon-driven element to fulfill a task. The goals of robotics in surgery in general are to eliminate unwanted motion, improve dexterity, facilitate minimally invasive operations, allow remote surgery, all while improving outcomes and maximizing patient safety. Robotics in general was born out of an idea to provide for remote surgery, which initially gained a lot of research dollars from the Department of Defense and the government. And they actually were successful in doing that back, I think, in 2001. But you know, there's a lot of different goals here. In spine surgery specifically, we focused up until now and continuing now on the placement of pedicle screws to increase accuracy, decrease complications, reduce radiation burden, enhance ergonomics, particularly if doing in the lateral position. Even if using navigation, it can be very awkward to do, especially the dependent screws. So having an arm that allows you to you know, be a little more ergonomic is more effective. Enhance dexterity and improve overall efficiency. These are the things they've been working towards. Some important timelines. You know, we kind of parallel, but 10 years behind the general surgery adaptation for robotics. You know, in 2004, Spine Assist from Mazor Robotics was first FDA approved, and then now we're up to the kind of the third generation robots, including the Mazor X Stealth Edition, the Excelsis GPS, the Rosa one, which really isn't being used for spine too much, and then most recently, Brain Labs Circ arm, which is a little bit different. It's more of a pneumatic arm that allows you to hold a trajectory while navigating. And then general surgery, you know, everybody knows about the Da Vinci. The Da Vinci is basically on its several iterations out, 20 years since it was first put into practice. You know, these numbers, you can take them how you want to take them. You know, I don't know what they're backed on, but these marketing firms have basically, you know, said that there's going to be a huge increase in dollars and market value for robotics. You know, most recently, one major company reported 100% increase in enabling technology revenue in 2021 compared to 2020. This was owed to robotics specifically. I think this was Globus Medical actually. So there is a lot of interest and everybody's interested. You know, there've been several dedicated issues in neurosurgical focus to robotics and neurosurgery, mostly spine surgery, but also including cranial surgery as well. And all the stakeholders are interested. Patients are always asking, you know, oh, are you going to use the robot? Is there going to be a robotic surgery, this and that? Surgeons are interested because they like the idea and it can help them. Healthcare systems are obviously interested in it from a marketing perspective. And then also trying if it can improve outcomes and decrease costs in the long run, despite the high cost of entry. And then industry is obviously very interested in this as well, because that's how they make their money. So we have had a good experience with robotics here. We initially started with Medtronic. Well, we have a long history with Mazor at the University of Miami, and then the Mazor X Stealth Edition at UM. I think total is about 36 cases that we ended up doing with the Medtronic, the X and X Stealth. These range from 1-level MIST lift to open long thoracolumbar instrumented fusions. I've talked about the results of this before, so I'm not going to go too much into that today. And we've even done some novel things that, like using the robot to target the disc space through Buchanan's triangle for robotic assisted endoscopic T-lift. And then, so, you know, I'll talk a little bit about the data, but, you know, now we have, just to mention briefly, Timur talked about it. We have the Globus Excelsis GPS at Jackson. I personally haven't used it, but I think we've been getting a good amount of use out of it, and it would be important for some resident to take interest and, you know, kind of compile that data and turn that into a project. So what's the general data? So the general consensus for robotics and spine surgery is that there are potential benefits, but the literature is very limited and heterogeneous. I mean, there's a lot of different studies, a lot of interest in people putting stuff out there, but in general, the quality of the literature is very poor. Most studies suffer from retrospective design. There's inconsistent methodologies, small sample sizes. There's obviously heavy industry involvement, whether or not this is explicitly stated or not. And, you know, it is a rapidly evolving technology, and there's many studies that are utilizing retired systems, which may not be comparable to the current wave of systems out now, which has actually been shown in a few papers. In terms of accuracy, just looking at a couple systematic reviews that have looked at this very recently, even here in 2022, This one large systematic review, including 36 studies, found a smaller risk of inaccurate screw placement with robotics compared to conventionally placed screws. This included 10 randomized controlled trials, which continue to show that difference. Whether or not this is a clinically significant difference is a big question, and that's not 100% understood yet. Nake et al. In 2022 showed the same thing, included 78 studies, significantly higher accuracy compared to freehand fluoroscopic guided and CT navigation. So we do know that CT navigation is very accurate, and it appears from these studies that what you could say is that the robotic guidance has a high degree of accuracy, at least on par with that of CT navigation. This is basically what I just said. You know, there's very few studies that are directly comparing robotics and CT navigation, particularly with current generation robotic systems. There's a couple have found here doing 190 PERC robotic screws versus 165 PERC navigated. There was no difference between robotic and CT navigated pedicle screw placement. These are cortical bone trajectory screws in this follow-up paper, which did show a significant difference. But whether or not that is clinical is, you know, a clinically relevant difference is the question, and not entirely clear. Here, this other study showed basically overall no difference for clinically acceptable screw placement, but there was a significant difference for optimal screw placement. So that's the question: is an optimal screw, does that justify using the robot? We do know that optimal screws, this one study here showed no difference in accuracy with robotic assistance, but using the robot did allow for placement of larger diameter and longer screws, which we know, it's very well understood that this increases the stiffness of a construct. So maybe getting the optimal screw to allow for fusion has some validity. But again, like I said, what the clinical outcome of all that stuff is really, it's really hard to make any conclusions from what literature is out because of the quality of it. But that's where the potential for research in the future lies. What we've learned here, as you know, we've used the robots for both Medtronic and Globus, is that there is a learning curve. You know, that's something that we've struggled with. But once you understand how to use the robot and that it's more soft touch surgery than anything else, because you can throw off the nav and move the arm regardless of whether it's really rigid or not, you know, can cause differences in your trajectory. We've noticed that open cases do definitely require a larger skin incision than what we're typically used to for just putting it in the old-fashioned way, because you need more, you typically have more medialized screws with the robot, and you just get a lot of soft tissue pressure on the driver shaft. There's a potential for shift in sky, which you have to be aware of when you're using it. But it definitely, I mean, we don't have the data for this, but definitely, I mean, from a common sense point of view, provides for less radiation exposure to the surgeon, at least here where we're very heavy fluoroscopic based. The advantages to robotics, you know, it's all about planning now. We know that the screws are accurate, but you know, there are some sophisticated planning software out that allows us to, you know, plan large constructs for deformity and this and that. So this can be very appropriate and beneficial. Here's just some pictures. This is using the Medtronic X-Align. This rod doesn't look so great right here. I don't know why it's kyphotic, but you know, just an idea that you can kind of line everything up the way you want to do it and do it. So, and then this is a picture from us actually using, you know, after having placed the screws, using or having planned the trajectory of these screws, planning trajectories through Camon's triangle to allow for passage of the endoscope and doing our endoscopic assisted robotic T-lift. So basically, in conclusion, robotic guidance provides a highly accurate placement of thoracolumbar pedicle screws, at least equivalent to CT navigation. Arguably maybe better if you can actually get a more optimal screw. I do think that robotic systems will be more commonplace during our careers, so it's useful to learn them, but it's definitely not a substitute for knowing how to do these kinds of procedures using conventional methods, being it either freehand or fluoroscopic guided, etc. Okay, that's it.